Hello and welcome to another live broadcast with MedStar Health. My name is Karen Zingle, and today I'm joined by neurosurgeon Dr. Teresa Wojtasiewicz, Dr. Kelly Orwat, a radiation oncologist, and Dr. Mahsa Mohebtash, a medical oncologist. Today we're discussing brain cancer. Brain cancer is extremely complex. So today we're going to talk all about diagnosis, risk factors, symptoms, and treatment options. Before we get started with our questions, let's meet our panel of experts. Dr. Wojtasiewicz, would you like to introduce yourself to our viewers and tell us a little bit about your specialty?
Hi, everybody. I'm Teresa Wojtasiewicz. I'm one of the neurosurgeons here at Franklin Square at MedStar. And my background and training was at Johns Hopkins. My particular specialty is, though I see patients with every manner of neurologic illness, including brain and spine, I'm particularly interested in patients with disorders of the brain and disorders of epilepsy and movement disorders. But I have a very deep interest in patients with a variety of different kinds of neurological tumors as well.
Okay, thank you so much. Dr. Orwat?
Yes, hi, I'm Kelly Orwat. I'm one of the radiation oncologists here at MedStar, Franklin Square and Bel Air. I did my training, both residency and medical school at the Medical University of South Carolina in Charleston, South Carolina, and then came here out of training and joined the group here at MedStar Health. I treat all forms of adult malignancies, but I'm very involved in our neurologic program as well.
Okay, thank you. And Dr. Mohebtash?
I'm Mahsa Mohebtash. I'm the medical director of MedStar Maryland sites for community oncology. I joined MedStar in 2009. Prior to that, I was in training at NCI, NIH for medical oncology. I treat all types of cancers, and if a patient has brain tumor and needs systemic therapy, we take them.
Okay. Thank you so much for being here today. We really appreciate it. Thank you to our viewers for tuning in. If you haven't done so already, give us the like, let us know you're watching. And if you have any questions for our experts, please ask them in the comments. I have some questions for you to get started today. Dr. Mohebtash, we're going to start with you. Can you explain to us what neurological cancer is?
So neurological cancers are tumors which can arise in the brain or in the spine. They can be primary or secondary. Primary means that they originate in the brain or spine. Secondary means that they are spread from other sites. Like if somebody has lung cancer or brain cancer or melanoma, they can spread to brain or bone, including spine. So this is how we define neurological cancers. There are many tumors which can happen in the brain and spine. Not all of them are malignant. We call them cancer when they are malignant.
Okay, thank you. What are the symptoms of neurological cancers?
So depending on the location of the tumor where it occurs and the rate of the growth of the tumor, symptoms may be different and vary. For example, brain tumors can present with headache, which is one of the most common symptoms of brain tumors. Or it could be a change in the current pattern of headache, because many people have headaches. If their pattern or intensity or quality of their pain changes, that could be an alarming sign. Seizures are other symptoms of brain tumors. Weakness, imbalance, sensory loss like numbness in extremities, slurred speech. Symptoms can sometimes mimic stroke symptoms. Symptoms related to increased pressure in the brain. Brain, as you know, is confined within a bony structure. There is not much room for brain to get bigger in that area. So if there is any swelling because of the tumor, people can get symptoms related to that, like nausea and vomiting. Tumors in the spine can present with pain, again with weakness, numbness, a loss of bladder or bowel movement. So it depends on where the tumor starts, but mainly headache, seizures, weakness, numbness, imbalance, nausea, vomiting are the symptoms we have to be vigilant about.
Okay, thank you. Are some individuals more at risk for brain cancer than others?
So that's an interesting question, because at least a couple of years ago, it was an area of lot of debate. I can say that most of the primary brain tumors are sporadic, means that there is no identifiable risk factor. Aside from relatively rare genetic syndromes like neurofibromatosis or cancer predisposition syndromes like Leaf-Romini syndrome, that if people have it, they are predisposed to many different cancers, including brain. There is actually the only established risk factor for primary brain tumors are exposure to ionizing radiation. Like if somebody has got radiation in the childhood because of a brain tumor, that tumor is cured, they are at risk to develop a second brain tumor. Other risk factors that has been an area that many people talk about, like low frequency electromagnetic field. Really, we do not have strong evidence to prove that it's a risk factor. You hear a lot about cellular phones and radio frequency fields. There have been numerous epidemiologic studies looking at the possible relationship between cellular telephones and developmental brain tumors. Nothing has been established. Those studies have been criticized for a lot of biases, and there is no significant biologic plausibility for that. However, there have been some not high quality, low quality studies that showed some slight increased risk in association with cell phone use, and WHO, World Health Organization, classifies radio frequency electromagnetic fields as a possible carcinogenic to humans. But as I said, it is not a firm recommendation. It is not completely approved.
Okay, thank you. That's really good to know. What about screening? Is there a way to screen for brain cancers, and how's that done?
Generally screening are done for tumors that are prevalent, and there are safe and easy way to find them at the earliest stage, and finding them in earliest stage can make a difference in patients' lives. Unfortunately, there is no screening tool for brain cancers. Unfortunately, they are not very common. However, some for advanced tumors, like if somebody presents with a stage 4 lung cancer, even if they do not have symptoms of headache, nausea, vomiting, imbalance, we screen for brain tumors in that individual. We do not do it for general population, but a woman comes with stage 4 breast cancer and has a new headache, we definitely immediately get a brain MRI, which we may not take if that person did not have breast cancer.
Okay, that makes sense. What about treatment options? What is the standard treatment option for brain cancer? And I've heard about immunotherapy on TV. Is that a treatment option for brain cancer?
So, when we say brain cancers and brain tumors, we are talking about a wide variety of different types, different grades, different rate of progression, if it started in the brain or it started somewhere else and spread to the brain. In general, I can say that every treatment depends on the origination of the tumor, but in general, treating any kind of brain tumor is a multidisciplinary approach. So surgery, radiation, and systemic treatment are part of that approach. Not everyone needs all of these modalities, but we approach these tumors in a multidisciplinary way. And so we will know all the possible treatment options, and the best for the patient is available. In terms of immunotherapy, for primary brain tumors, it's still not standard of care. There has been some studies showing that it has activity in primary brain tumors, but it has not been FDA approved yet. Lots of studies are going on with checkpoint inhibitors, pembrolizumab and nivolumab, We hope we get some of them approved. We have other systemic therapies like chemotherapy, VEGFR inhibitors, which kind of block the new formation of blood vessels in the tumors. We have targeted therapies that some of them block some targets on the surface of the tumors, which can cross the brain-body barrier and reach the tumor cells. However, things may be different if the tumor has started in a different area. Like for lung tumors, which has a spread to the brain, we use a lot of targeted therapies. They can cross the blood-brain barrier. We use immunotherapy for those. But if you are talking for the tumors which originated in the brain, then that role is still not established completely.
Okay. Thank you very much. What about prevention? Can brain cancer be prevented?
Primary brain tumors, if we can avoid ionizing radiation, that in some cases like nuclear bombing is inevitable, or if somebody has a childhood tumor, which the only way to cure it to give radiation. So I'm not sure if we can really prevent them, but we can definitely prevent some of the primary tumors which have a high potential to spread to brain, like lung cancer, smoking cessation. If you don't get lung cancer, you will have much less chance of having a brain tumor spreading from lung to your brain, or breast cancer or colon cancer. So screening for lung cancer, breast cancer, and colon cancer with low-dose CT of chest, colonoscopy, and mammograms. There are ways to prevent the primary tumors which have a potential of brain metastases.
That's good to know. Thank you very much.
And just to interject,
Yeah.
one of the other things that I unfortunately see sometimes is, one of the best ways to prevent a tumor that originated somewhere else in the body from spreading to the brain is by making sure that if you know that you have cancer somewhere else, even if it's early stage, that you take it seriously, because a lot of cancers can spread to the brain if they're not treated right. If the patient, for whatever reason, doesn't get their cancer taken care of, that really increases the chance of it going to the brain or the spine.
Yep.
That is
Good point. That makes sense. Yeah. Thank you. And Dr. Mohebtash, my last question for you is in terms of clinical trials. Are there any clinical trials currently underway that for brain cancers? Yeah. Okay.
Many clinical trials are ongoing for different modalities, for surgical techniques that I leave for our neurosurgeon to talk about. Many studies are going on for radiation that Dr. Orwat can talk about it. And systemic treatment, the same. We are actively working of modification, drug antibody conjugates, some vaccines that have viral vectors which can transfer and deliver systemic therapy better to the brain. Not all of them are approved, but it's in the pipeline. And in MedStar Health, we have several studies for brain tumors open, and we are looking at opening even more.
Okay, thank you, Dr. Orwat. Do you want to talk a little bit more about the clinical trials that Dr. Mohebtash mentioned?
Yes, so there are a fair number of clinical trials that have been available. Some are still open here, some are working on getting open. There are a couple really big areas of interest in radiation oncology when it comes to tumors that involve the brain and or the spine. One is limiting how much we have to treat and trying to spare important structures that correlate with long-term side effects. So a big area that we've looked at is sparing the portion of the brain that helps with memory formation, to try to decrease the amount of short-term memory issues people have down the road after they've had to have radiation for brain tumors that have spread from somewhere else in the body. So we've had several trials open looking at that, both in what we call the whole brain treatment area, but also looking at moving more towards targeted radiation, so stereotactic radiation, and trying to spare as much of your good, healthy brain as we can when we're doing these treatments.
Makes sense. Thank you so much. Dr. Wojtasiewicz, I have some questions for you. We talked a little bit about treatment earlier. Is surgery a standard part of treatment for neurologic cancers?
Yeah, absolutely. So as Dr. Mohebtash had said, there's, brain tumor refers to such a wide variety of different kinds of tumors. And, when someone finds they have some lesion in their brain, it's not even always cancer. It's not even always a tumor. So a lot of things can even look like a tumor that's not even a tumor to begin with. So because there's such a different variety of tumors, the treatments are also really quite variable. But surgery is definitely a big part of a lot of different kinds of tumors of the brain. And surgery accomplishes basically two things. One is relieving the pressure from that tumor on that healthy brain. And two is whatever that is, it's controlling that cancer that's in the brain to begin with. And for for some of the cancers or tumors that are just in the brain and nowhere else, surgery can be curative. For some kinds of low-grade tumors, the surgery is the only treatment that a patient may ever need.
Okay, thank you. What is minimally invasive surgery an option for brain cancers?
Yeah, absolutely. So, in neurosurgery as a field, in every subspecialty of neurosurgery, we've really been focusing on technology to make surgery less invasive, safer, and to make the recovery faster for patients. So we always do, the least amount of manipulation of the brain tissue that we possibly can. And one of the things that I really find with patients is that, even for a large tumor with a large resection, the recovery tends to be, a lot faster than folks expect. The brain is, really a very resilient organ. So patients really do recover a lot faster than they would anticipate from procedures that are understandably very scary and intimidating. But we've been able to really make surgery much safer and the recovery much smoother and faster for patients.
That's great. Let's talk about that a little bit. Can you talk about side effects from surgery and what does the recovery look like?
Yeah, so the side effects and the recovery from surgery really does depend on what part of the brain that we're operating on. The biggest thing that I tell patients is that they're going to have a headache and incisional pain. Typically, patients tend to have more incisional pain and more headache if they've been having a lot of headaches and a lot of pain before surgery. For patients where they weren't having a lot of pain before surgery, the incisional pain from the surgery tends to actually recover pretty quickly. And by about 2 weeks, a lot of patients have weaned down to the point where they're taking over-the-counter pain medicine like Tylenol alone. A little bit of some fogginess of memory, regardless of where we're operating in the brain, does tend to be part of that recovery. A little bit of some dizziness, sometimes a little nausea as well. Those are all very common for any part of the brain that we're operating on. For tumors in the skull base, so that's kind of in the base of the skull, the muscles that we have to resect tend to be those are big, tough muscles. So the incisional pain in those surgeries tends to be a little more, and there tends to be some neck stiffness. I always tell patients that, when those muscles recover, you gently let your neck move. And the more that you gently stretch those muscles, the faster that you recover.
Makes sense. So is that
one of the things I do want to highlight is that, we, in addition to the team that, you're seeing today, our medical and radiation oncologists who are really critical, in our multidisciplinary team, the folks in the hospital, including our neuro ICU doctors, are also really critical for making sure patients recover quickly and safely.
Okay, thank you very much. We talked about multidisciplinary approach. Can you talk about how is care coordinated between the different treatment types, so how they work together? Can you talk about the tumor board discussions and a little bit more about the multidisciplinary approach?
Yeah, so, we all work so closely together, and patients, brain cancer is a very serious illness, but we've been able to treat patients very, very effectively. And you can keep someone extremely healthy and in really good shape as long as you're all working together and making sure every part of that team is working. So basically, whoever happens to encounter that patient first, whether that patient is referred to the radiation oncologist, whether they're seeing their oncologist because they have a known cancer diagnosis, or whether, I see the patient first because an MRI shows something that's abnormal and we're not quite sure what it is. We all make sure that the patient is coordinated with every other member of that team so that they can see all different sides of their treatment all different sides that are going to be a part of their treatment. And anytime, these tumors are complex and there's a lot of different kinds of treatments, and it's not just about the right kind of treatment for the right kind of tumor, it's about the right kind of treatment for the right kind of person. There are some patients where, surgery is really, not a good choice for them, and radiation is going to be a fantastic solution. And then there are other patients where, radiation isn't going to be the right choice for that particular person. So we all meet the patient and discuss, look through the pictures and discuss together. And tumor board is, not just, the individual doctors taking care of that individual patient. Tumor board allows every single radiation oncologist that's a part of our team, every single neurosurgeon, every single medical oncologist to all talk together. And for some of our more complicated cases where, the tumor is behaving in a way that's a little more unusual, or someone where the standard treatments really haven't worked the way that we wanted to, and we're thinking about more experimental treatments or trials, that's where those patients really, are served particularly well. So we all discuss those patients all together as a big group.
Right. That makes sense. Yeah. Thank you for explaining that. So I have some questions, Dr. Orwat, for you. Let's talk about, so we talked about different types of surgeries, options, different treatment options. Let's talk about radiation. Can you explain how radiation is used in treating brain and spine cancers?
Sure. As everyone else has said already, the brain and spine cancers are a pretty broad group, so it really depends. In the setting of a cancer that originated in the brain, so we call it primary brain cancer, then oftentimes radiation comes after a surgery's been completed, sometimes along with a form of chemotherapy from a medical oncologist like Dr. Mohebtash, sometimes by itself. It really depends on the individual type of cancer. Other times, radiation therapy may be all that person needs. As Dr. Wojtasiewicz has said, we do each meet with the patient individually and talk about what options are on the table available to them and proceed in the way that's best for them. When it comes to tumors that originated somewhere else in the body and then end up in the brain or the spine, then radiation therapy almost always plays a role. Occasionally it's done after surgery, but very often it's done on its own. And we coordinate with the patient's medical oncologist the timing of those treatments, because as was previously alluded to with some of the newer immunotherapies, there are now times on occasion where radiation therapy can wait a little while. It becomes a very patient-specific discussion.
Okay, thank you very much. Are there different types of radiation therapy options?
There are. So there are a couple of options now, and it seems that that pool expands every so many years. So more and more patients are able to do what we call stereotactic radiation, which is very targeted, typically 1 to 3 treatments, occasionally as many as 5, targeting just the tumor itself with a very tight treatment plan that allows us to protect everything else in the area. So again, we're trying to really minimize the damage and the side effects caused by the treatment to the best of our ability. Not everyone is a candidate for that or needs that. So sometimes with primary brain tumors that are a little bit larger, we do a more traditional type of radiation therapy. But again, everything's done in a very conformal way where it's individualized for the patient and as safe as possible. Occasionally, patients will benefit from proton therapy, which is another type of radiation. And that's something that's available at a few centers. Georgetown is one of them, that's MedStar Hospital. So in the rare cases where patients really need that, we're able to plug them in as well.
Okay, thank you. What about CyberKnife? CyberKnife, can you talk about that, what CyberKnife is and how that works for treatment?
Absolutely. So CyberKnife is a type of radiation therapy machine. It is on a robotic arm, so it gives us immense flexibility in how we design the radiation treatment for each individual person. So we can have, instead of, just a handful of beam angles, we can have 100 beam angles if we need to, which allows us to get that very tight treatment plan that I talked about with the stereotactic radiation. So you get that very high dose to the tumor while having a very low dose to the area around the tumor, or even no dose.
Okay, thank you. So you just mentioned the low dose of radiation, that being a benefit. Can you talk about other benefits of CyberKnife for treatment?
Absolutely. So CyberKnife is a machine that allows us to treat, in particular, brain tumors or spine tumors that have spread from somewhere else in the body. We can do it in as few as a single treatment. So it really shortens the number of treatments a patient needs and allows them to get onto their systemic therapy, be it chemo or immunotherapy, sooner. It also allows us to really limit side effects. So by having that tight treatment plan, you do experience less headaches, less dose to things like, the optic structures of your eye, your structures that allow for hearing, all of those important areas. And in the spine, in front of the spine, you have parts of your GI tract, your esophagus, your swallowing tube, and we're able to protect those more than we would be able to without the CyberKnife by having that tight treatment planning option. It also has a role in some non-cancerous tumors and conditions. So things like a meningioma, we can get a very good treatment plan for as well, and sometimes treat those patients in a single treatment. Or even things you don't think about as much with radiation, like trigeminal neuralgia. We work with our neurosurgical colleagues on cases of trigeminal neuralgia that have been challenging to manage, and that gives another option for them as well.
Those are great benefits. Thank you so much. I'm going to pause.
As you may think, the name of the treatment is CyberKnife. A lot of times, CyberKnife has benefits not just compared to other kinds of radiation, but CyberKnife is often a treatment that we can use instead of surgery. And as CyberKnife's gotten better and better, we're finding we're able to save patients from a surgery and offer them, a 30-minute, one session treatment that'll fix their problem and treat their tumor without an open intervention.
Great, thank you. I'm going to pause for a moment. We have a question from our audience. Thank you for your question. This is from Brenda. Thanks for your question. And then if anyone watching has other questions for our experts, please ask them in the comments. This question asks about, I think it's a surgical question. So Dr. Wojtasiewicz, if you can help me with this answer. The question is it true once you open up, so I guess once the tumor is exposed to air, it can get worse. So I think there's maybe a myth out there that once you open it up to air, it can get worse. Can you talk about that?
Yeah, so that's something that I've heard. It is a common misconception that I've heard. And, I will say, as I said before, patients wake up very, very quickly from brain operations because the brain really is very resilient. And a lot of times, especially for a secondary cancer that's spread to the brain, we may only be seeing the tip of the iceberg. We may be seeing the biggest lesion, and there may be tiny lesions that are so small that we can't tell that they're there. But when we're doing surgery, the surgery is removing the tumor. It may not remove every single bit of tumor that's in the brain because there may be tiny bits that are in other spots that we're not even operating on that are too small for us to even see on an MRI. But, the surgery, by removing as much tumor tissue as possible, it overall improves the chance of controlling that cancer. And there are patients that even, by the time a cancer spreads from somewhere else to the brain, it automatically is described as a stage 4 cancer. I have lots of patients who I follow who have had brain operations for stage 4 cancer and go into a stable state where their cancer remains at bay. So, even patients with the stage 4 cancer that spread to their brain, surgery can offer them, be part of the overall treatment plan that gives them a good long-term control of their cancer. That said, the phrase of, when the air hits your brain, anytime you've had a brain procedure, you want to be patient with yourself. I tell patients it's a little bit like having a concussion, because just that having that brain procedure, you're going to feel a little foggy, your memory's going to be a little off. Those are all temporary side effects. I've had a number of patients actually notice that they didn't when their tumor was picked up because they were screening because they had cancer somewhere else, when their tumor was removed, they describe it as like a light turns on again. They didn't realize how symptomatic they were from the tumor until it was gone. So it's important to give your body some time to recover, but at the same time, be mindful that it's, surgery is part of the global, cancer program to make sure that that cancer is, kept in control as best as possible.
Okay, well, thank you very much for that. And thanks again, Brenda, for asking that question. So we've talked about a lot regarding brain cancers. As we mentioned, it's complex. We talked about diagnosis, risk factors, symptoms, and treatment options. So before we end our broadcast today, I do want to make sure that we take a moment to share with our viewers what's one of the top key takeaways that we want to make sure, or something that we mentioned that we want to reiterate before we wrap up our broadcast. Dr. Orwat, I'll start with you. What would you like to say to our viewers before we wrap up?
Yeah, I would reiterate that cancers of the brain and spine do represent a very wide variety. So everything is very individualized and very tailored, not just based on the type of cancer that you have, the type of tumor that you have, but also all of the other individual characteristics of the person come into play as well. Not only are the tumors a wide variety, people are as well. So everything being an individualized treatment course is important.
Great, thank you so much. Dr. Mohebtash, what would you like to share with our viewers before we wrap up?
So first, I want everybody to be up to date with their screening for breast, colon, and lung cancer, stop smoking. And then I want people to be vigilant and listen to their body. Like, if you have a headache for a long time, which doesn't go away, pay attention to it. Seek help, talk to your primary care physician. Or if you have some weakness or imbalance, or even nausea, vomiting that you attributed to a gastrointestinal problem, it's not going away, talk to your doctor. It could be the sign and symptom of something more serious. So we should not downplay the symptoms happen to us, weight loss, unexplained. Of course, I don't want people to be extremely worried. Many of these things are really not cancerous and not a sign of cancer, but if something doesn't make sense to them or takes longer than they should, they really have to be very vigilant and seek help and seek attention as soon as possible.
Great advice, thank you. Dr. Wojtasiewicz, what would you like to share with our viewers before we end the broadcast?
Yeah, so, I definitely agree with, Dr. Mohebtash to be very vigilant of, symptoms. And though fortunately brain tumors are very rare, so, you don't need to think not every single headache is a brain tumor, but listen to your body because, brain tumors are very varied. And though some of them, the prognosis is very poor, the prognosis for brain tumors can be very reasonable. And we can give patients a very good quality of life and even potentially cure them of their tumor. The earlier a tumor is detected, the less invasive the treatments are going to be, and the overall better the outcome is going to be. So the sooner that you get to see the doctor, the better. And really patients listening to their bodies really is the best way to, pick up on those subtle signs. A lot of times, by the time someone is seen, gotten to see, a neurosurgeon or an oncologist or radiation oncologist, the symptoms have been going on for quite a while, and folks have been letting it to the side, thinking, oh, it was just an ache or something that was just going to go away on its own. And then the other thing I do want to also highlight is that a brain tumor is not a hopeless situation. Brain tumors are very treatable. And we are getting better and better at getting patients, even the tumors that don't have good prognosis now, we're working really hard to get patients as healthy as possible and to really, work on fighting brain tumors of all kinds.
That is wonderful. Thank you so much. Yeah, you can think of a brain tumor, brain cancer as being extremely scary. So thank you for sharing, all three of you, your perspectives and your insight. And I learned a lot today, and I hope our viewers did as well. So thank you to everyone who joined us today. If you would like more information or to schedule an appointment, you can call 443-777-7603. We'll include that in the comments as well, so you have it. Thank you again for joining us. We appreciate your time. That's all we have for today. We will see you next time.
Sure.